Let's discuss a very interesting case performed by my student, wherein we're going to reflect on the importance of creating well-constructed paracentesis incisions, managing an iris prolapse, and finally the challenges that occur with excessive blue dye being introduced into the anterior chamber. Let's move to watching this surgery. So here's a patient with a grade 2 nuclear sclerosis, and the surgeon has made a fairly large, well-constructed paracentesis incision. But the fact that it's not stained and she's not understood what exactly is the plane of the incision, she's finding a lot of resistance at the inner lip. So what's the mistake made here? The lack of counter pressure. Merely stabilizing the eye with the limbs forceps would enable the surgeon to introduce the cannula into the anterior chamber. Now here's the second mistake, making yet another paracentesis incision to ease the entry of the cannula. So if the problem was inability to visualize the plane of the incision, one could just inject a little bit of blue dye to stain the incision, which would then ease the entry of the cannula into the eye. Now, having created the second paracentesis incision, the surgeon is able to now introduce the instruments into the eye. However, notice that after introducing some Phacoemulsification plus, there was some iris prolapse. And now notice, whilst attempting to introduce blue dye into the anterior chamber, look, because of lack of stabilizing the eye with the limbs forceps, the surgeon is now once more unable to introduce the blue dye cannula into the anterior chamber. So unfortunately, as you see, a third incision is now made. After which you'll now notice with ease she's now finally able to introduce some blue dye into the anterior chamber. The next mistake here is I like to inject blue dye under a bubble of air that limits the amount of blue dye entering the eye and actually stains the anterior capsule fairly uniformly. The amount of fluid introduced into the eye and the amount of time taken to wash out the blue dye is unnecessary. After washing out the blue dye, you will notice that there is a significant iris prolapse. And in all likelihood, the misdirection of the fluid behind the iris, along with the excessive fluid-induced raised intraocular pressure and with the associated large paracentesis incision, has resulted in this iris prolapse. So now a second paracentesis incision is made, after which we will now see how one attempts to reposit the iris. You see, merely pushing the iris into the anterior chamber is not going to work, because once the iris has prolapsed out, the tendency for it to come out again and again is going to remain. So what would work here is introducing a dispersive viscoelastic to push the iris posteriorly, and also once you introduce the iris repositor into the eye, you need to push down into the anterior chamber posteriorly to release the fluid from the eye, after which the iris, once it goes in, is likely to stay in. The surgeon then attempts to perform rhexis from the same incision. I think a smarter thing to do would be to perhaps take a suture at this incision, make a smaller side port incision, and then continue with the Capsulorhexis, because as you can see, the iris is tending to prolapse once more. So once more, we attempt to reposit the iris. Notice how the iris repositor is pushed downwards, fluid is released, which maintains the iris now in the anterior chamber. Having successfully reposited the iris, a suture is taken, after which the main incision is created at the 12 o'clock position. Following this, the case is now taken over by the senior surgeon. In view of the iris prolapse, I chose to use a 20 gauge MVR to create the left paracentesis incision, after which I will now complete the Capsulorhexis. After doing so, note how I introduce a little more dispersive viscoelastic into the anterior chamber in the area of the prolapse. I now proceed with the hydrodissection. Note the billowing of the iris and the tendency to constriction of the pupil whilst I perform the hydrodissection. Following the completion of the hydrodissection, I introduce a dispersive viscoelastic into the anterior chamber, and then I proceed with the nucleus disassembly and emulsification. The technique, as you can see, that I'm performing is that of a direct chop, wherein now I'm going to break down the nucleus into smaller emulsifiable fragments, after which each fragment, as you will see, is going to be emulsified. What starts to become obvious when I start emulsifying the fragments is the absence of the red glow. You will notice that the entire vitreous seems to be blue, meaning that the blue dye has traversed via the zonules and gone into the vitreous and stained it. The rest of this part of the nucleus disassembly and the irrigation aspiration, I would like to highlight the intraoperative limitations that we are going to find because of the absent red glow in this case. As you can see here, we're getting to the end of the fragment emulsification. Following the emulsification of the fragment, the loose epinucleus is also aspirated, after which we now will proceed to the bimanual irrigation aspiration. This is what we're going to be working with: the absence of any red glow because of the vitreous being stained with the excessive blue dye. We now start with the bimanual irrigation aspiration. What I did find is that the loose cortex that's visible within the pupillary area could quite easily be held and emulsified. Overall, I did find, however, that the absent red glow resulted in the cortex not being delineated as it naturally is against the red glow, which made the removal of the cortex rather challenging. I now swap hands and try and remove the cortex from the inferior and the right side. Notice also the tendency of the pupil to be pulled whilst aspirating the cortex, and I'm wondering whether this actually might be a patient with idiopathic floppy iris. Let's now watch with care and caution how the rest of the cortex is removed. We now come to the end of the cortex wash. I'd like you to also notice the tendency to iris prolapse through a well-constructed 20-gauge MVR paracentesis incision. Following the completion of the cortex wash, I introduced some viscoelastic into the anterior chamber, and we now proceed with the implantation of the single-piece monofocal IOL in the bag. Note the limitations of visualizing the opening of the haptics because of the limited red glow. Whilst performing the visco wash, some of the cortex that could not be removed from the 6 o'clock position is now removed, after which the excess viscoelastic is now removed from the anterior chamber. Whilst removing the instruments after completing the visco wash, notice the iris prolapsing once more. I introduce some air into the anterior chamber, after which you will see the successful hydration of all the incisions. This now brings us to the end of this surgery. I do sincerely hope that you found this video tutorial useful. Thank you.